Hello. People keep saying we have no long-term data on gender-affirming hormones. After 30 years caring for transgender patients, let me set that record straight. We have data going back more than 50 years. It's not perfect, and it doesn't say the risks are zero. I'm Dr. Dave, a transgender health and hormone specialist, and I've been doing this for 30 years myself. So let's take a look at this and talk about it. First, an important distinction. More than 50 years of data does not mean we have 50-year randomized trial or that every person was followed for 50 years. It means large clinical cohorts include people who began treatment as early as 1972, with some followed for decades. And our adult data is going back much further than our data on people who started treatment during adolescence. That distinction does matter. So let's begin with the Amsterdam cohort of gender dysphoria. Researchers there assembled records from thousands of transgender people treated since 1972. One mortality analysis included more than 4,500 adults who received hormone, representing over 57,000 person years of follow-up. The study found higher overall mortality than in the general population. I'm not going to hide those findings, but I'm also not going to misuse it. Among transgender women, the majority or major excess causes included cardiovascular disease, lung cancer, HIV-related illness, and suicide. Among transgender men, mortality was higher than in general population women, but not general population men, and the excess was largely from non-natural causes. That study cannot prove that hormones caused those deaths, or that hormones had nothing to do with them either, because it was observational and did not compare hormone users with otherwise similar transgender people who never used hormones. The authors concluded that the pattern did not point to one specific hormone treatment as the explanation. It pointed to the importance of cardiovascular prevention, smoking cessation, HIV care, mental health support, and addressing the broader conditions in which transgender people are forced to live. Now let's talk about the heart and blood vessels, because this is where the evidence becomes very specific. In 2018, Kaiser Permanente's STRONG study included nearly 5,000 transgender people and almost 100,000 matched cisgender comparison people. In transgender women, the clearest signal was venous blood clots compared with the control group. There were roughly 3 to 4 additional clots per 1,000 people at 2 years, and approximately 14 to 17 additional clots per 1,000 at 8 years. In the subgroup who started estrogen during the study, researchers also observed a signal for ischemic stroke after longer exposure, especially beyond 6 years. But there were relatively few long-term events. Average follow-up was only about 4 years, and the study could not reliably separate risk by estrogen formulation or route. The science did not stop in 2018. A newer Dutch study published in 2026 examined more than 2,700 transgender women and nearly 24,000 person years of follow-up. After adjusting for socioeconomic status, heart attack risks were lower than in general population men and similar to general population women. Ischemic stroke risk was similar to both groups, but the clot risk remained higher, about 2.4 venous clots per 1,000 person years, approximately 1.8 times the comparison population. So the honest conclusion is not estrogen destroys your heart, it's not estrogen has no risks. The most consistent cardiovascular signal for transgender women is venous blood clots. That's why we avoid ethinyl estradiol, address smoking and other clotting risks, and often favor transdermal or injectable estradiol for people at higher risk. What about testosterone? In the same 2026 Dutch analysis, transgender men experienced about 1.9 heart attacks per 1,000 person years. That was substantially higher than the rate in general population women, but it was not statistically different from the rate in general population men. Stroke showed a smaller increase compared with women, but not men, and venous clot risk was not increased at all. That comparison matters. Some cardiovascular risks may shift toward a typical male pattern on testosterone, but we still need more data to know whether testosterone adds risk beyond that, particularly when levels are supraphysiologic. That's why good care includes monitoring blood pressure, cholesterol, glucose, testosterone levels, and obviously hematocrit, not reflexively withholding treatment. How about bone health? This subject is often presented as either puberty blockers destroy bone or there's absolutely nothing to monitor. And as always, neither statement is accurate. A 2023 study followed 75 young adults who had received puberty suppression and then gender-affirming hormones for a median of nearly 12 years. Bone density scores fell during suppression and later returned to pre-treatment levels in most sites. The important exception was the lumbar spine, in particularly assigned male at birth, where recovery was incomplete and may have been related to lower estradiol exposure. A second study published in 2026 followed 117 people who started hormones during adolescence for up to 10 years. Bone density scores remained within the normal range overall, although prior puberty suppression was associated with some lower density at some of the sites. No pathological fractures were ever reported, and that's reassuring. But these studies are still too small and too young to settle lifetime fracture risks. The responsible message is to optimize estradiol or testosterone, vitamin D, calcium intake, weight-bearing exercise, and bone monitoring when clinically indicated. We also have meaningful cancer data. A Dutch nationwide study followed 2,200 transgender women and about 1,200 transgender men. Among transgender women, 15 invasive breast cancers were diagnosed after a median of 18 years of hormones. Risk was higher than in cisgender men, but still lower than cisgender women. Among transgender men, 4 invasive breast cancers occurred after a median of 15 years, a rate far lower than cisgender women. That doesn't mean no cancer risk. It means risk changes with anatomy and hormone exposure. Screening should be based on the organs someone has, their age, family history, surgeries, and duration of exposure. Other studies also include medications we now use differently, or we avoid them entirely, like ethinyl estradiol carried more clotting risk than modern estradiol, and prolonged high-dose cyperterone acetate is associated with meningioma risks. Historical data therefore teach us how to make modern care safer. They should not all be treated as if every hormone regimen were identical. Finally, what about mental health and quality of life? Systemic reviews consistently find reductions in depressive symptoms and psychological distress after gender-affirming hormone therapy. Many studies also report improved quality of life, body satisfaction, and self-acceptance. But I wouldn't call every psychological outcome settled. Most studies are observational. Many are small, and hormones occur alongside social transition, improved autonomy, and other care. Those benefits are real, but the research cannot isolate exactly which part produced each improvement, and it can't prove from study alone that hormones prevent suicide. So what do more than 50 years of evidence actually tell us? Not that these medications are risk-free. Nothing in life is. Not that every lifelong question has been answered, and definitely not there is no long-term data. The evidence shows specific risks that can be discussed, screened for, and reduced. It also shows meaningful benefits, particularly reduced dysphoria and psychological distress for appropriately selected people. That's what evidence-based medicine looks like, not pretending risk is zero and not pretending evidence is zero. If someone tells you we have no long-term data, ask them a better question. Which outcome, which medication, which population, when compared with whom? Because that's where the real science begins. I hope this was helpful. I'd appreciate it if you share it with someone who needs the facts and tell me which claim about gender-affirming hormones you want me to fact-check next. Thank you for all your support. We'll talk soon, and if you hit those buttons, boop, 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 I'd appreciate it. Love, support, and protect one another always. Meow, meow.